Hi, everyone. It's really my pleasure to speak to everyone today about some of my favorite topics: topography, keratoconus, and of course, crosslinking. I'm from Miami, Florida, and I'm an ophthalmologist at the Center for Excellence in Eye Care. I work for a lot of companies. These are my disclosures, and I think, more or less we'll talk about some companies here, but overall, it's just a general overview of the various technologies. And this on the right is the hospital I'm at, Baptist Hospital in Miami, Florida. So I always love to start off with some questions and thoughts. And the first one is, what percent of patients who present for cataract surgery actually have dry eyes? And it's an important question because when we're doing topography in patients about to have cataract surgery, we can get inaccurate topographies due to dry eye. So you should be aware that dry eye is actually quite common. And it's in about the 80% range. So then the second question is, so again, it's very common, dry eye. So, be aware of that when you're doing topography in patients who are scheduled for cataract surgery. And then, of course, we know, I was going to point out that we love topography and also OCT of the macula, in our patients undergoing cataract surgery, but dry eye affects the topography. Now, in regards to crosslinking, what do we usually see after crosslinking for keratoconus? Does the corneal shape remain stable? Does the corneal shape improve, or does it worsen? I think it's important to understand that the corneal shape often improves most commonly. So it's not really to stabilize the cornea. We actually do see lots of improvement. And I'll show you examples of that during the talk. Also, can patients who are older actually have worsening of keratoconus? And the answer is actually yes. We can actually see people in their 60s, 70s, and older that actually can have progressive keratoconus. So just because someone's a little bit older doesn't mean that their cornea is stable. And lastly, what's the chance, another question to think about, that a patient who undergoes crosslinking will require a second crosslinking procedure? And the answer is, it's not 0%. It's actually 1 to 7%, depending on the study. The point being that after crosslinking, you need to follow your patients year after year to make sure they're getting better. And if not, if they're getting worse, you may need to do a second crosslinking procedure. So let's just talk a little bit about just some general stuff about cataract surgery. And then again, we're going to get into why topography is important. But we know that our patients have high expectations. They want a very rapid visual improvement. We do also obviously want to avoid cystoid macular edema by using non-steroidal drops to help prevent, at least that's what I do in my practice, to prevent CME. And then also what's really common in taking care of patients is to treat the ocular surface for dry eye. So we use artificial tears, we may use topical steroids to smooth out the dry eye and get a better reading of the topography before cataract surgery. And the key is patients have very high expectations. Obviously, again, these are 3 important tests that we're looking for. We're looking for patients that may have subtle irregularities of their macula. We're going to look at people that have subtle irregularities of their cornea, like EBMD. And then we're going to look at people that have no actual irregularities of their cornea, but they get a funny topography because they have dry eye and throws off the readings, as in this case. So here's a patient to think about. 68-year-old patient comes in for cataract consultation. They have loss of best corrected visual acuity. Their vision is 20/50, normal is 20/20. They have the OCT shows a normal macula. Slit lamp exam is normal with really no dry eye, and they have a cataract. And so the question is, does this patient have a corneal condition that may affect the patient's cataract surgery outcome? And the answer is that even with a normal slit lamp, the answer is yes, they can have abnormal corneal shape. This is a patient that has some mild keratoconus. You can see the red, where the arrow is going to, is the steep part of the cornea. This irregularity will lead to some reduction in quality of vision after cataract surgery. But this patient's cornea is completely normal. You won't see anything on slit lamp exam. The only way you'll identify this is to perform a topography prior to cataract surgery. So that's why it's important to identify. Now, I pointed out that dry eye is very common, And we did this study at 9 sites across the United States, looking at the incidence of dry eye prior to cataract surgery. And then we asked the patients whether they had symptoms of dry eye. And it's surprising that 87% of the patients had very minimal symptoms, either never or some of the time. There's only 13% of the patients that actually complained about a good amount of dry eye. So the point being is that your patients aren't going to tell you they have dry eye. They're not going to report dry eye symptoms. So you can't ask them how their eyes feel to identify dry eye in cataract surgery patients. So you have to do some tests. So hope you can still see me. You have to do some tests. And one of the tests I love is called the tear breakup time. And tear breakup time is used to measure the health of the ocular surface. And the question is, what is considered abnormal for tear breakup time? Is it 10 seconds, 7 seconds, 5 seconds? And my understanding is that most people use about 10 seconds as a cutoff, although 7 seconds is even a little bit more common. But it is, so normal is 7 seconds or longer, for example. And in our study where we looked at all these eyes scheduled for cataract surgery, we found that the average tear breakup time was in the abnormal side, 4.95 seconds, and 62.9% had a tear breakup time faster or less than 5 seconds. Wow, if you think about that number, we're asking patients to go and sit in front of a topographer, sit in front of their biometry to measure the corneal astigmatism and keratometry. And if they're opening their eyes for the test and their tears are breaking up, you're going to get an abnormal testing results. So it's very important to identify dry eye and treat dry eye. We'll get inaccurate keratometry readings for cataract surgery. And also we looked at corneal staining. We had 50% of the patients that had central corneal staining, and 77%, 76.8% had some degree of corneal staining on their cornea. So again, this is a very high number of patients that are coming in. They're coming in for cataract surgery, but when we looked at dry eye was exceptionally, very, very common for these patients. So here's our summary of the study. Most patients were asymptomatic. Tear breakup time was very abnormal in a lot of patients. And corneal staining was also a problem in 50% with central corneal staining. Now here's an example. This is a patient prior to cataract surgery, and you can see that there's a lot of irregularity in both maps. On the map of the right eye, you see a big blotch of red, central and superior. See if you can use my arrow and see my arrow here. And then we have this green area just below it. In the left eye, we see something, this looks relatively symmetrical centrally, but then you have a dropout spot and then this red area below. So this red area is abnormal, the white area is a dropout. So this patient is obviously abnormal, and this is actually very classic for dry eye. And these are dry spots. And if you look here on this patient's slit lamp exam, you can see that it's not surprising it had this very irregular corneal shape. This is the picture of the right eye. You can see how irregular this was. Here's another example. 86-year-old female coming in for cataract surgery. And you see a couple areas of red. You can see the area of red kind of centrally. Then it gets a little, then you see the other colors that change and it comes back to red. Red is a sign of being steeper. And so this patient has irregularity, and it's due to dryness. We did the keratometry and the biometry, and it told us that we should pick an 18.5 diopter lens. But this is before we treated dry eye. So what happens after you treat this patient's dry eye? What happens to the IOL calculations? Well, this is after a month of treatment with topical steroids and topical cyclosporin. Better, not perfect, but a lot better. And now the Ks are flatter, and the choice of a lens is now at 20.5. Before it was 18.5, and now it's at 20.5. So by treating the dry eye, it resulted in a change in the prescription, or sorry, in the power of the lens selection of 2 diopters. So you can see how important identifying and treating dry eye can be for getting good outcomes with cataract surgery. Here's another example. This topography is quite irregular. You see centrally these red areas. This irregularity is very common. You can see it in dry eye and EBMD, but this patient had significant dry eye. It's a 60-year-old. We were told to pick a 20 diopter lens with his first reading, and then again after we treat them again, you can see things are less. Less, and then you can see here that if we went with the 20 diopter lens, you can see now it's shifted a little bit where our final outcome would be hyperopic. The K's got flatter, so we would not want to, that would be here. Let me just go back here. Our better choice would be a 21 diopter lens. So again, first it told us to pick a 20 diopter lens, but then now the better choice is to pick the 21 diopter lens. Some readings, sometimes you could get multiple K readings on your IOL Master, whatever device you use. If they take multiple measurements, it tells you that something is going on, that there's dry eye or an unstable tear film. Here's another patient. You can see there's this topography is another example of an irregular topography where there's some red spots, and we see 2 red spots in a topography. That's abnormal. You typically don't see these changes in elevation. We get steep part of red, it gets a little flatter. You see yellow right in the middle there, and steep again. That's quite irregular. Again, you can see that with EBMD, but it is more common for dry eye. And you can see again some irregularity spots. So you just have to identify these patients. And then you can see now I showed you the example before here where it's quite different after they measured it a few times. And then we treated the dry eye, and now it's a little bit more symmetrical, 3 readings. So in patients with dry eye and myopic gland dysfunction or an unstable tear film, there's a variety of different treatments we can consider. They can include topical steroids, topical cyclosporin, topical ephedrigras. We can use punctal plugs, and then agents for blepharitis or MGD, which can include topical azithromycin, warm compresses, hypochlorous acid spray, and many others. But I think the key is whatever treatment you use, whatever treatment you use here, you want to take the measurements you took the first time, treat the patient medically, and then bring them back and do another set of readings to make sure that to get better readings and compare. And you often will see improvement in the shape of the cornea, better, more consistent readings. And then once it's stable and repeatable, then you can plan your surgery and move forward with cataract surgery. Here's another example of an irregular corneal shape on topography. You can see here that there's this big area below where you see this. It goes from yellow to orange to red, even to white. And then there's another area of red just above that. So this is an example of some significant irregularity. The reason, though, is I'm not sure if you can see just below, there's actually a very big tear film. The patient had, someone put a drop of artificial tears in this patient's eye just before they did the topography. The patient had dry eye. I guess the technician thought, okay, let's put a drop in, but now you have too much tears and it threw off the readings completely. So it's actually not a good idea to put artificial tears in just prior to topography or biometry. You'll get inaccurate readings. So you can see here that the patient was still treated for dry eye, which they had, and they came back and you can see things look much more symmetrical 2 weeks later, and then the tear film was normal. And now here's an example of 2 maps. Then they're 2.5 months apart. And you have the map on the left and then the map on the right. And it looks like this patient has progressive keratoconus. And if you saw this patient from 2.5 months later, you'd be, oh my gosh, this patient is really getting worse. The keratoconus is advancing. But there's a little trick actually. I actually reversed the readings, and it's actually the other way around. In real time, we got the first reading, which looked like keratoconus with a red inferior, so steeper below, flatter above. But the patient had dry eye, and we treated the dry eye for 2.5 months, and then now they look much better. So this is important to understand that if patients have dry eye, and they have keratoconus, if you don't treat their dry eye, their keratoconus could be looking worse, even though they're actually stable. It's also important if you're doing crosslinking. If you're crosslinking a patient and seeing them back 6 months later, a year later, and they have dry eyes, you might think they're getting worse again when it's just the dry eyes. So it's very important to always, at all times, identify dry eye and treat dry eye to more accurate and avoid surprise like in this patient. Now, when we're reviewing topography, we want to be able to look at maps and make decisions as to what is going on with the cornea. And so in this example, you see the red in the middle part of the cornea, and this is called central steepening. And we see central steepening in two situations. One is with keratoconus. You can see a central keratoconus, but what we see even more commonly is people had previous hyperopic LASIK or PRK in the past. Now they have central corneal steepening. So this is post-hyperopic LASIK. Obviously, the formulas we use for planning IOLs in patients that have had previous LASIK, we need to know if they had previous myopic or hyperopic LASIK. You can see here these patients had previous hyperopic LASIK. Now in these maps, you see blue flat areas in the middle. This is central flattening from previous myopic LASIK. So this is what we expect to see after previous myopic LASIK, nice round symmetrical optical zones. Now this is a patient that came in to see me for cataract surgery, and first thing we got to do is figure out, did this patient have previous myopic or hyperopic LASIK? And when you see this area of red around, you're thinking, okay, this is previous myopic LASIK. But then you see there's this tongue of red coming right to the middle. So if you can see the middle part is, there's this red extending right to the middle. And so this is actually an area of irregularity right in the middle of the visual axis. It can really throw off a patient. So this patient came to me for cataract surgery. I identified this ahead of time, but I didn't quite explain to the patient that it would impact their vision as much as it ended up doing. So it's really important to identify this, explain to the patient they may have some reduction in their quality of vision after cataract surgery, because it can truly impact the results. And the patient was actually disappointed in their outcome from cataract surgery because it was all due to the irregularity of their corneal shape. This patient had LASIK in 1995. They ended up with very small optical zones that over the years have decentered. And you can see that there's quite an irregularity in the corneal shape. And what I like to do is zero in on the very center, on the very visual axis. You can see it in both eyes. We'll do the top one first. The right eye has an area of 40.5 above and 20.6 below. So it's quite irregular, and there's a very big gradient. From 20.6 to 40.5 is a very big change. So this cornea right in the middle of the patient's visual axis is quite irregular. The left eye, thankfully, is less irregular. You can see it goes from 38.8 down to 34.9. So there's still irregularity, but less amount. But this patient, both these eyes will likely not do well after cataract surgery. They'll be able to see somewhat better, but they'll end up needing like a RGP lens. But what I love is a scleral contact lens to really give good visual results. Now, here's a patient that had previous myopic LASIK, and then we look at the IOL Master and we see something very concerning, that the Ks are asymmetrical. So the first question I like to ask here is, when someone undergoes LASIK, how much astigmatism do patients usually have 6 months to a year later? And the answer is usually under a diopter, and most commonly under a half a diopter. You know, maybe 0.6 or 0.5, but it's rare to be at a diopter, very rare to be at 1.4 diopters as it is in the left eye, and you wouldn't see it in the left eye unless there's a problem. So this patient had previous myopic LASIK, but just looking at these Ks, we're concerned that there's something wrong going on in the eye. And this is a picture of the map. And you can see that this patient had a corneal topography where there's this rim, which is what we expect in previous myopic LASIK, but then we have this area of red right below the center. So what is that area of red? Is it a dry spot, EVMD? Those are possibilities, but this actually ends up being post-LASIK ectasia. And so this area of steepening coming right through the area of flattening. And so just to be aware of this type of pattern. And this patient will, after cataract surgery, not see great. They will need some type of scleral contact lens, scleral contact lens to see better. Now here's another patient. They're interested in a refractive outcome with cataract surgery, but this is their topography. So here we're seeing something quite abnormal. We're seeing this area of red off to the side, and then it's flatter centrally, and then it's peripherally, comparatively, it's flatter. This patient has an area of steepness in this one area, and what's causing this? It doesn't look like keratoconus. Keratoconus can occasionally present on the side like this, but this is a little bit irregular, so it doesn't look like keratoconus. It turns out that this patient had EVMD. So you can see that these are the whorls in this patient's cornea, and the patient had this irregularity that was due to the epithelial basement membrane dystrophy. In regards to treatment, these patients do very well if you just remove the epithelium. You can smooth it out if you want with a diamond burr or a laser, but the key is you smooth it out, and the patients would go over a couple of months where the epithelium grows back, and over time they end up seeing a lot better as the corneal shape is smoother. So I hope that was a good overview of topography. And now we're going to go next to crosslinking. And I love crosslinking, and we'll talk a little bit about crosslinking. Okay, so crosslinking is a procedure that's FDA, in the United States, which is where I practice, it's FDA approved for keratoconus and post-LASIK ectasia, but it actually works quite well in pellucid marginal degeneration. So it does have a couple uses overall. We typically think of keratoconus as something that we use to stop the progression of keratoconus. However, I want to make sure everyone's aware that it does far more than stop progression. Most patients will get improvement in their corneal shape, and that can lead to improvement in vision over time. It's not immediate, it's a time type of thing, but over time, patients can get improvement in their vision from crosslinking due to improvement in corneal shape. And that can occur over 1 year, over 3 years, over 5 years, over 7 years. But the longer you wait, the better often the shape will be. So I recommend that we consider crosslinking in all patients that have keratoconus, pellucid, or ectasia, because we are going to see improvement in the corneal shape over time with crosslinking. There's two types. We'll talk just a little bit about epi-off and epi-on. So epi-off obviously has a little more risk, but still the results with epi-off are quite good. One thing to consider is that younger patients with keratoconus can progress very rapidly. So if you have a younger patient with keratoconus, especially starting to get more moderate to advanced, you want to treat them as fast as possible, because if you wait a couple of months, then they could have more progression. So the sooner you can treat them, the better. Okay, so our goal with keratoconus is we want to stop the progression of keratoconus, and we have other things we can use as well. We can remind patients not to rub their eyes. That's a big risk factor. We have the epi-off with either manual scrape or with a laser reshaping of the cornea, and with the epi-on procedure. The epi-on is what I've been doing for the last 10 years. It works very well. Then we have other things like rings. I put Intex here, but it could be rings. We could also do conductive keratoplasty combined with crosslinking, topo-guided or topography-guided PRK with crosslinking. Obviously, some patients will need a transplant, but with scleral lenses and crosslinking, we can really do a really good job of avoiding the need for corneal transplants. So here's a couple of pearls that I always like to point out. We want to identify keratoconus as early as possible. I did, just to share, I have treated patients as young as, I guess, 4 or 5, but typically around 7 or 8 is when I've ended up treating the kind of really the youngest group was really around 7 or 8. You can really start to see it more commonly. The patient who was younger than 7 had a genetic condition that is how they developed keratoconus. So, but typically 7 or 8 years or older is when we treat them. And as soon as you identify that you want to treat them, the younger patient, as soon as possible. Same with young adults in their late teens and 20s. The sooner we can treat them, the better. But actually, Any age of patients can undergo crosslinking. Again, younger patients can have it and do quite well. Older patients can also do quite well with crosslinking, where it will stop the progression and we'll actually see improvement over time. And then we want to educate our patients to avoid eye rubbing. Some patients will need some drops, like they may need some anti-inflammatory drops, some antihistamine drops, lubrication drops, but we want to encourage them to feel comfortable and not to rub their eyes. So here's an example. 14-year-old male patient comes, so 14-year-old, they're in 8th grade, they come in for an eye exam. They've never worn glasses. Their vision is not as good as usual, and now they have some loss of uncorrected visual acuity, but their best corrected visual acuity is 20/20. So in most cases, with this type of finding that they can be corrected in 20/20, people do not usually perform a screening topography. Okay, the refraction though gives a little clue that there's some asymmetry in the amount of the astigmatism. Again, the patient's correctable 20/20, but when you see an asymmetry in the astigmatism, you should definitely consider performing a screening topography. But anyone who has a change in their vision could also benefit, because young patients can develop keratoconus early that's picked up in topography, but not have a normal corneal topography, normal slit lamp exam. So you have to be suspicious. If someone comes in, they're reporting reduction in vision, an 8-year-old, a 10-year-old, a 12-year-old, and they need glasses, and there's a change in the prescription especially, I would be suspicious of keratoconus. So one of the problems why keratoconus is often discovered late is that the slit lamp exams of keratoconus are typically not visible until you get to moderate to severe keratoconus. So mild keratoconus or even subtle keratoconus, the exam of the slit lamp exam of the cornea is normal, so you can't see anything irregular going on. So that's why often keratoconus is not picked up till later, because people don't do screening topographies. And this just points out that significant keratoconus can develop prior to significant vision loss. And here's an example of 4 patients that I saw in my clinic, and guess what the visual acuity was without glasses of these 4 patients, 4 eyes of 4 patients. So surprisingly enough, the first one had uncorrected visual acuity of 20/20 in that eye. So they would have passed any eye exam. But same with the second one. This one looks even more advanced. Third one, 20/20. Fourth one, 20/20. So all these eyes actually were able to see 20/20. They had some irregularity, but they could read the 20/20 line. So this is why often people present late with keratoconus, is because the doctors screening them don't realize that they may have keratoconus, because slit lamp exam is normal. It's only if you did topography. So why are patients with keratoconus typically diagnosed after they've already had experienced loss of vision? Again, it's as I point out, people can show up late, but we do identify a lot of patients on cataract consults and also LASIK consults. So advanced keratoconus can also be discovered during screening, like if a doctor who's fitting a patient of theirs with contact lenses or glasses is noticing changes in the refractive error, especially if there's more astigmatism, just be suspicious and order topography. And these patients, these are 2 patients, and they're 44 and a 38-year-old. They came to see me for LASIK. They've been seeing their doctor. They were wearing glasses and contact lenses every year and never gotten topography. If they had gotten topography 3 years ago, 5 years ago, they likely would have had some more subtle abnormalities, but they would have been picked up early and could have had crosslinking much earlier. Instead, they showed up, like this to me. And now, of course, we can perform crosslinking, but it would have been nicer to have caught them 3 years ago or earlier. Now, talking about picking up people early, this is a family member of mine, a very important family member of mine. At 9.5, she had normal topography. Her uncorrected visual acuity was 20/25, but overall things look relatively normal. And then she came back at age 12. Now her uncorrected visual acuity dropped to 20/80 in the right eye, 2100 in the left, although it's correctable to a very good vision. And thankfully, we ended up performing a screening topography. And this is the pedicam. You can see these areas of orange inferiorly. There's significant inferior steepening in both eyes. And I showed you the previous one. So we know this is a shift or a change from how things were when she was 9 to 12. So she did develop keratoconus, and I did treat her when she was 12. She's done very well. She's had improvement every year, although I haven't seen her this year because she had the treatment back in 2012. But she's now 20. She's in college and she's doing great. And it's all because we really caught her early and treated her with crosslinking at the age of 12. So here's a 10-year-old male. And this is one of the cases where I always think, gosh, I should have really jumped in sooner. So the patient came in to see me in January of 2014. I know it's a long time ago. But then they came back I said, they wanted to have crosslinking, but they weren't ready. And, the mom wanted the child to wait until there's a little break in school. So they decided to wait till April. And you can see that, well, it may not be obvious on the picture. If you look at the numbers on the picture where the cone is on the right, and this kind of April 22nd, 2014 image, which is 3 months later, you can see that there's actually, steeper numbers. And then the Kmax went from 58 to 63. The cornea thinned a little bit as well. So the point being here that we want to catch these patients earlier. And if we catch them, don't wait 3 months to treat them with crosslinking. See if you can get them treated in 2 to 3 weeks or so before they have more progression. This is a difference map. Difference maps are what I really like to use to follow patients that have keratoconus. We can use the difference map to look at changes in every point, and it's color coded. So the red is where it's steeper, blue and purple is where it's flatter. You can see in this map that over the 3 months, the cone has gotten steeper or bulged outwards, and the top part is flattened more. Okay, so how can we diagnose keratoconus and monitor progression? I think the key is screening and look at difference maps. And here's an example of a difference map. This patient came in at age 14. They then waited to see me for 18 months. You can see the significant change in this patient's corneal shape over this time frame. So again, we knew the patient had keratoconus. She just wasn't able to come back and didn't want to have the treatment at that time. And then you can see she went from a Kmax of 53 to 63 over that 18 months. So, and this is the difference map showing significant changes. Red's where it got steeper, and shows you how much of a change this patient had over the 18 months. And again, you can see the red's where it's redder, red is where it's steeper, the blue is where it's flatter. Now, we showed you this picture before, just pointing out that you need to watch patients that have had previous LASIK for irregularities. So again, this is what myopic LASIK should look like, a nice round optical zone. You can see here, this patient doesn't have a round zone. They have this little dimple at the bottom. And you can see this is back in 2013. And then when the patient came back in 2018, so 5 years later, you're now seeing some more progression where the bottom part's getting steeper. You can still see that irregularity, the optical zone. And the difference map helps to see what's happened. The patient's gotten steeper. There's been this change over time. The other eye actually had ECTASIA already. So this is the right eye in 2013, and I treated this patient's right eye at the time, but I followed the left eye because they were seeing so well. And then it was just over the 5 years, I noticed that they were getting this progression, so we decided to eventually treat the left eye. But the reason I followed the patient so closely is because the right eye did have ECTASIA after LASIK. And ECTASIA after LASIK can be a little tough to diagnose. There's a patient that has this green zone right in the middle, inferiorly, and then that was 2017. If you look at 2012, it was round. There was no green zone. So that's area kind of developed over time. You see the difference map shows that there's some central steepening consistent with the map, one map to the other, showing that over 5 years, this patient had progression of the keratoconus. And again, this is a patient where the reason I followed this eye over the 5 years is because I had the other eye had ECTASIA already, which we treated with crosslinking. So I think it can be a little tough to pick these patients up, but again, if they had previous LASIK and you see an area of green or steeper area inferiorly, be suspicious for early ECTASIA. And this is the patient's right eye and the patient's left eye. They had previous myopic LASIK. So now we're going to talk about a little bit more about topography and like when to consider a toric lens in patients that are scheduled for cataract surgery. So there's a patient, 70-year-old female with a history of LASIK. We can see here that the cornea is centrally steep. So the Kmax is 52.2. So this patient must have had hyperopic LASIK. They've now developed some astigmatism. And this is actually a picture from March 2008, when they were 70 years old. The Kmax is 52.2. They ended up having cataract surgery in 2011, no AKs, no LRIs, no corneal incisions. But the patient, and I asked the question, would you have considered a toric lens? I think you could have considered a toric lens back in 2008 when you saw this patient. They had this very symmetrical astigmatism. So I think a toric lens could have been an option. But what happened 10 years later, the patient actually had seeping of their cornea. Their Kmax went from 52.2 to 57.1. The astigmatism axis changed a little bit. So I think that the toric lens would have still worked, but just, there's now more astigmatism. And this is a difference map showing this significant central, just I guess, paracentral area of redness consistent with progression over this time period. So again, this is a 70-year-old patient that from age 70 to age 80 had progression of their ECTASIA after previous LASIK. So we always get this tough, challenging situation. What to do first? You have a patient that has keratoconus, like in this case, and they have cataracts. Do you do cataract surgery first? Do you do the cross-linking first? What do you do first? So this patient, I'm just going to show you from 2014 to 2016, had some pretty nice changes in the corneal shape after cross-linking. The red area is much better in 2016. And this is a difference map showing significant flattening inferiorly. That's the purple and the blue. Significant steepening superiorly. And so you can see how the corneas have been reshaping over this time frame. So I guess my point being is that what I like to do is a slow process. I do like to do cataract surgery first, treat the patient, with cataract surgery, and then follow them over time. They should be seeing quite well after cataract surgery, not perfect, but better. And then you can always add cross-linking in the future. So there can be some variability of corneal shape following cross-linking. We typically see some progressive flattening of the corneal shape over the first couple of years, but the Ks may not be perfectly stable. You have to be careful of that. So that's why repeat measurements are helpful. You want to treat dry eye, which can make the Ks somewhat irregular. And then as far as waiting, there's a question I just asked, but I typically like to perform, if I'm going to perform cross-linking, I usually like to wait about 6 months, but it doesn't matter too much because you just have to know the patient will slowly get some flattening of the cornea over time. So you have to target a little myopia in these patients that have cataracts and keratoconus. So here's a patient, what happens over time? This is a patient that had cross-linking and 5 years later has follow-up. So the cross-linking in 2011 and 2016, the patient comes back. You can see that the Kmax went from 45.1 to 40. So that's the K average. I apologize. I don't know what happened to the Kmax there. You can see that the Kmax from the first visit in 2011 to 2016 did flatten quite significantly over time. And so over 5 years, you see this nice improvement in the corneal shape. The difference map shows us that the steep part got flatter, the flatter part got steeper, so the cornea is reshaping. And then if we look at 5 years, then we look again, this patient came back a year later, and you can see even further improvements where the Kmax got better, got even a little bit better over time. Went from there to some, the final Kmax was 47, went from 53.6 to 49.2 to 47.9. So nice improvement. So even 5 years after surgery, they haven't completely stabilized. You're still seeing here example of a patient getting further better from year 5 to year 6 after cross-linking. So here's another 70-year-old, another older patient. They came to see me. You can see their birthday above. This is 2011. They had cataracts and they wanted cataract surgery first. You can see that their Kmax was 54.5. They had cataract surgery shortly thereafter. And then they came back in 2016, and now the Kmax went from 54.5 to 56.0. The cornea got a little thinner. Sorry, the cornea stayed about the same thickness-wise, but that was the thinnest location. But you can see the Kmax getting a little steeper. Nothing too worrisome. We look at the difference map and see, clearly there's some steepening, so we'll have to watch that over time. It's 2016. Then from 2016 to 2018, there's further steepening. the Kmax went from 56 all the way up to 57.1, so further worsening over this next time frame. This is the overall difference map, again from from 2016 to 2018, showing continued progression. So just pointing out that someone in their 70s can still have progression of their corneal shape. Just because they're older doesn't mean that they can't progress. So we know that Epi-Off has had a long track record. It's been around since 1998. It was approved in the United States here in 2016, but I've been part of a protocol, so I've been doing Epi on throughout the time period of us offering crosslinking. So I started crosslinking in 2008, so I guess really I'm at 12 years of crosslinking, and from years 2010 on, it's only been the Epi on, which can work very nicely. So the key is that how do we know something's working nicely? We need to evaluate the outcomes. I do like to look at difference maps as well as the vision and refractive error. So here's a patient example, 21-year-old Caucasian male with ectasia already after LASIK. You can see their pre-op vision was 20/40 uncorrected and 20/40 best corrected. And then the patient cross-linking, you can see there's a little bit of improvement from Kmax of 43.4 to 42.9, but you can see the best corrected visual acuity clearly improved. And you look at the difference map, and the corneal shape is getting more regular, just explaining why the best corrected visual acuity improved in this patient. Here's a 16-year-old. So we did this change, so they went from 45.5 to 45.3, so not a huge change from 2012 to 2016. Here's the difference map, but so we do know that there is some improvement going on where there's flattening. The blues where it got flatter, greens where it got steeper. So there's some improvement over this time period. Again, I guess the key thing I just wanted to point out for this map is that we can't, even though the Kmax didn't improve a lot, the fact that the corneal shape, you can see that the shape change was quite significant. And so that's why I like looking at difference maps to see changes over time. Here's an example of a patient with a pellucid pattern. They had their Epi-on crosslinking in 2010. They came back in 2015 and their Kmax had worsened from 46.9 to 47.7. So what does that mean? Is this patient having progressive pellucid pattern keratoconus over this time period? When we look at the difference map, we actually see centrally that there's a little area of flattening just below the center and a little area of steepening above. So the central cornea actually regularized, so it's much more regular. The bottom part, there's still a little bit of progression, but nothing too worrisome. I'm pretty happy overall. This patient was really happy with their vision, which had gotten better over time. You can see the example of patient's best corrected visual acuity changed from 2030 to 2040 from 2010. Then it went to 2025 in 2012, and 2015 is 2020 in the left eye after cross-linking. So even though the Kmax is a little steeper, this patient had significant improvements in their vision overall. So what is the rate of progression of keratoconus despite cross-linking? I always like to look at these studies. This one study was an early study, found 7.6% chance of progression. This study found 3.17% chance of progression. So progression is a real risk. And something that, let me see one thing here. So progression is a real risk. I usually like to quote about 3% risk with crossing. So just we need to be aware of this, that there is a risk of progression. Why do some patients present despite initial cross-linking treatment? Maybe it was not the best cross-linking treatment itself because there wasn't enough riboflavin. Maybe UV light wasn't centered on the weakest part of the cornea. Could be the patient was rubbing their eyes a lot, which is a risk factor. They could have had elevated eye pressure, or maybe it's not. It's just an artifact. It's not a true progression that they're not seeing well because of the contact lens which they were wearing, which could, if they didn't take it off, they may have some degree of contact lens warpage or things like that. So we call it pseudo progression, or it's not true progression. So patients can progress for real, but then also you have to be careful that it's truly a real progression. It's not due to dryness or some ocular surface irregularity causing what looks like to be progression over time. So this is a patient at crosslinking in 2012, and then they came back in 2016. Now you can see the map looks very symmetrical, so they almost normalized. Their Kmax went way down. The difference map shows significant improvement with the red arrow, with the red box and the arrow pointing to the steeper part. The purple area is the flatter part, but I just love difference maps. They tell us so much. You can see this cornea's gotten very symmetrical over this time period. And again, I love difference maps. They tell us the story, then what changes over time. So purple is flatter, red and yellow are steeper. And this is the change in Kmax over time. I plotted out the Kmax change over time for one patient. They start off at 55.8. You can see that over time, that they get down all the way down to 49.8. So from 55.8 to 49.8. So a pretty big change over this time period. So the 6 diopter change over 5 years. So this is the same patient where we looked at what's called difference maps. And difference maps are my favorite because it just shows where the flatter it's getting, the darker blue it'll get. You can see that this last map is really nicely blue and you get a lot of flattening. Again, these progression maps can help us understand what's going on over time. Now, I guess, a caveat to all this is that some patients with advanced keratoconus can get high drops and they'll recover. And the key is, do you need to do a transplant on them or not? These are patients that are wearing scleral contact lenses and actually having very useful vision. So I would, and then Dr. Edward Boschnick is kind enough to share them with me, but I would avoid no transplant at all possible. You'll be surprised how well people can see with the scleral contact lens. So I think this is my last case. Thank you guys for being so patient. There's a patient that's 27-year-old but has very steep cornea. It's 81.3 is their Kmax. Their best correction visual acuity is 20/80. And thankfully, they have a clear cornea, and so it's a quite steep cornea. And then the patient underwent crosslinking. This is with Epigon as part of our clinical trial. And see that there's this change. The best corrected visual acuity improved to 20/40. Kmax dropped from 8 to 8.9. Look at the difference map where you see flattening inferiorly, steepening superiorly, and then we're really getting some nice reshaping going on with this patient over this time period. And then there's a patient with very advanced keratoconus. So in summary, you can see here, this is just crosslinking young patients, but we want to identify keratoconus early, treat early, avoid eye rubbing, and watch for recurrence. And I hope all the information I provided in this lecture today was helpful to everyone. I really appreciate being invited to be here.